field of clinical medical ethics. It's truly outstanding. A couple words about what we have been doing in the center and what is on the horizon. It has been a big year for us. There is going to be a new concentration in biomedical ethics that will be available in the Master of Science in biomedicine. That will be an option beginning in the fall of 2025. Additionally, we're starting a new online certificate program in clinical ethics beginning in 2025. We are continuing with our signature fellowship in clinical medical ethics, which most of you know is the Siegler Fellowship in Clinical Ethics, and that is an increasingly competitive fellowship to get into, and we have an outstanding group of fellows who are here today and participating. And so for those of you who think you might be interested, I would encourage you to talk to some of our current fellows. They are a truly talented group. We do also have a new full-time postdoctoral fellowship in clinical ethics. This year we have our first 2 fellows in that program and look forward to reviewing applications soon for the next year of that program. A couple words about the conference. The fact that you are here means that you know something about the conference, so that's good. But for those of you who may not be aware, we did solicit abstracts. We had an outstanding group of faculty involved in the program committee who did a blinded review of abstracts with scoring, and I think it has resulted in an outstanding program, and I want to thank those of you who did submit abstracts and for the faculty who helped review them. Tomorrow I will be introducing the MacLean Prize winner, Dr. Mildred Solomon, and I will formally introduce her tomorrow, so won't say much more today. We do have a few different sessions. As you'll see in the program, this is a plenary session. A little bit later, we'll have breakout sessions that will be small groups, 2 in the balcony and 2 off to my left if you go out the doors. There are the breakfast sessions that many of you participated in this morning. There'll be 4 different sessions tomorrow for informal discussion if you would be interested. For those of you who are presenting or who do great scholarly work in clinical ethics, I would encourage you to submit your manuscript to the Journal of Clinical Ethics, which is sponsored by the MacLean Center, but ably led by Executive Editor Norman Quist, who is also with us here today. And so if you have questions about the Journal of Clinical Ethics, please see me or Norman. A couple additional things about logistics. There is a single bathroom across the hall outside, but there are multiple more up the stairs to the balcony. There's also an elevator to the balcony if you need it. We are trying to be good stewards of the environment, and therefore we encourage you to use an electronic version of the schedule. But for those who prefer a printed copy, we do have a small number of those available for you. The oral presentations will be 15 minutes each with 5 minutes for discussion. This is always a difficult thing for a group of people who are engaged in the discourse of important ideas, and that is staying on time. And so I realize that's challenging, and especially for me. And so I've decided to not moderate any sessions, but in fact to have 3 of the outstanding MacLean Center faculty moderate the sessions. So if you are speaking, do note the moderator for your session who'll be sitting near the front. And if they start waving to you, that's usually a sign that you're running out of time, okay? So if you spend more than 15 minutes speaking, you'll have less than 5 minutes for the question and answer. We do have a group of people who are attending virtually, so we will ask that those who are asking questions to come up and use the microphone. There's one on each aisle, and we are also interested in questions or comments from those who are attending online, and so we'll have a mechanism to engage that way as well. A few final thank yous to the museum staff, to the meeting achievement staff. You may have seen them downstairs at the registration desk outside. I want to thank the MacLean Center staff and especially Haley Beck, who's really stepped up and done an incredible job. As you circulate between sessions, maybe give everyone an extra thank you. I mentioned those who submitted abstracts, and I thank them. The speakers, I thank you, but I actually thank all of you who are here, because it is activities such as this where we engage in conversation. We may not all agree, but the fact that we're here and participating in the discourse is what makes it so valuable. And so I want to thank you for being here. I look forward to our conversations over the next couple days. And with that, I want to turn things over to the moderator for the first session, my colleague, Dr. Megan Applewhite, who is Associate Professor in Surgery, my colleague in Endocrine Surgery, and also an Associate Director of the MacLean Center. So Megan.
Good morning, everyone. Welcome and thank you for being here. This is my pleasure to be able to introduce the speakers for the Health Policy Plenary Session. Our first speaker is Dr. Karen Devin. Dr. Devin is a former MacLean Fellow and now a surgeon ethicist and associate professor at the University of Toronto. Her clinical practice is in endocrine surgery at Women's College Hospital and the University Health Network. She is also the medical director of the Medical Assistance in Dying program at UHN. Today she's going to be speaking on to consent or not to consent, genomic sequencing of deceased individuals. Please welcome Dr. Devin.
Thank you. Thank you so much. It's great to be back, as always. Even though I was the one introduced, I'm going to also introduce the senior author here who's sitting in the audience. That's my husband, Dr. Jordan Lerner Ellis, because he is going to help me field some of these questions around genetics. He's an associate professor at the University of Toronto and the director of molecular genetics at Mount Sinai Hospital in Toronto. He's a clinician scientist at the Lunenfeld Tannenbaum Institute and on multiple international consortia on genomic data sharing. So I'm going to basically tell you a story. It's interesting that every time I come back to speak at this conference since my fellowship, I've never been in a surgical ethics session. So we could actually start this story as far back as my fellowship here in Chicago, because that was when Jordan first declined a date with me since he was still in Toronto. But I'm going to fast forward to 10 years later, where he co-PI'd a study, received $4.2 million in 2020 to do a study on implementation of serological and molecular tools to inform COVID-19 patient management. This was funded by the Canadian Institute of Health Research and Genome Canada. This is a prospective study, observational cohort of adult patients with COVID-19. And the goal was to look at the relationship between genetics, serology, and disease and symptom severity, to hope to better understand the relationship between genetics and immunity, and to implement novel serological and molecular tools to inform the management for patients with COVID-19. As I said, it started prior to vaccination, but continued post. And the name of the study, HostSeq, was to sequence 10,000 individuals, their genomes, their T and B cell receptors, and the virus with SARS-CoV-2. In Toronto, we had 1,500, it's not we, it's he, had 1,500 enrolled participants with confirmed PCR COVID-19 infection and measured antibody responses through blood samples. Results were returned to participants, and the outcomes of receiving information, because these were entire genome sequences, were assessed through surveys and qualitative interview. This included blood samples from deceased individuals. No PHI information was collected for those individuals. And this is just one of those charts that explains the whole study and as an overview. There's no volume, I think, on the video. I'll be the volume. Hello, honey. I'm home. Great. So Jordan came home after having put in the REB for this study and said, what should I do about this REB question? With regards to the first route by which to obtain specimens, it is not clear from the submission who and how the next of kin will initially be approached for the study. And this was in reference to samples from deceased patients. And so I did what any supportive spouse does in this situation and said, go figure it out yourself. But my ethics brain had been piqued. And every once in a while, someone, you know, over the years since this fellowship, someone will ask me a question and they'll say, can I ask you an ethics question? And my first reaction is always to think or assume that the dilemma has already been thought through or solved. And so why reinvent the wheel? And then I realized there really wasn't any wheel. And so what I tend to do is to go back to first principles, because often things like consent are such a given to us now that we forget the why. And then going back to that really sometimes changes how we understand the principles anew. And it certainly did in the case where the REB's question was, of course, very appropriate. And I thought, what is the purpose of informed consent? So just a quick review. Autonomy, understanding the risks and benefits. Health research often involves potential risk to participants, physical or mental well-being, and informed consent ensures that participants are fully aware of these risks, as well as potential benefits of the research, such as contributing to medical knowledge. Transparency, researchers must present information in a way that is understandable to participants, which is especially important in health contexts where medical jargon may be involved. That's so they can make truly informed decisions. Ethical standards like privacy and confidentiality. Health research frequently involves sensitive personal health information, and informed consent includes assurances about how participants' data will be protected, which is critical for maintaining trust and ethical standards. Legal protections, ensuring that their participation is voluntary and that they can withdraw at any point without affecting their medical care or access treatments. And finally, the ongoing communication, especially some community engagement and cultural sensitivity. So, according to federal regulations here on human research protections, the common rule, a human subject is a living individual about whom an investigator obtains data through an intervention or interaction or identifiable information. And while research involving deceased individuals is not subject technically to the federal regulations on human research protections, and therefore not technically under the regulatory purview of the IRB, other regulatory and ethical issues should be considered in the design and conduct of this research. For example, the HIPAA applies to individuals' protected health information for 50 years after death. In Canada, what we went back to was the tri-policy statement. So this is the statement on ethical conduct for research involving humans, and it provides ethical guidance that applies to all research involving human participants, including their data and biological materials, conducted under the auspices of an institution eligible for funding by the federal agencies like the CHR, which funded this study. To read the tri-policy statement, specific items that apply, researchers who have not obtained consent for participants for secondary use of identifiable human biologic materials shall only use such material for these purposes if they have satisfied the REB that the use of identifiable human biological materials without the participant's consent is unlikely to adversely affect the welfare of individuals from whom the materials were collected. Secondly, researchers who have not obtained consent shall only use materials for these purposes if they have satisfied the REB that identifiable human biological materials are essential to the researchers, and that, of course, they will take appropriate measures to safeguard. So firstly, so we wrote a response. Firstly, for our research, the deceased patients were unable to be harmed. Now, I recently read a robust philosophical debate on this point where they differentiate between hurt and harm, and in retrospect, I might have been a little more nuanced with the REB about these terms. But briefly, they discuss the Aristotelian idea that concerns of well-being for offspring descend people's lifetime, contrasted with Epicurus' annihilation thesis. Contemporary thinkers have argued that harm can only occur when a person is actually subjectively worse off, and that while defamation, for example, is something that could be morally wrong, it doesn't necessarily result in harm. Others, like Nagel, argue that the dead can be harmed even though they cannot be hurt, and this can be done without their knowledge. It doesn't require an experiential component. So the continuation of the social contract, like for example, wills, means that we have to act as if there is such thing as postmortem harm or quasi-harms. Second, genomic data is different than other biological materials in that they are technically personal health information. However, they already act as a coded identifier, which must be analyzed separately and then linked to other identifiers in order to be able to identify individuals. So we said, while we are intending on returning genetic results to participants who are alive and have the opportunity to go through a decision aid process, DNA from deceased people will not be analyzed individually in our cohort. They will only be analyzed in aggregate through the HostSeq project, such that there is no risk of identifying information that could be linked back to them, nor have any relevance to other family members. And of course, there were many different safeguards around that specific point. Now, recently, authors have argued that genetic data really follows more of an information ethics approach rather than a medical ethics one. It's based on thinking about digital remains, not organic life. So for example, someone's Facebook profile. In studies, people actually consider their social insurance number more private than their medical health information, which is interesting. We could also think about sort of an explanted intracardiac device as another piece of information rather than health data. Whether we think of DNA as biological or personal data, samples stored in a lab freezer or a database are not themselves sources of information, but rather the resource from which information is constructed. So that being said, the moral duty to respect the data subjects isn't absolute when there are more pressing moral concerns. With respect to the second point of the tri-policy statement, given that the goal of our research was to identify genes or DNA variants associated with COVID-19 outcomes, the severity of disease and immunological response, the deceased cohort represented an essential group to the study. I think that's obvious, and it's impossible to seek consent from deceased individuals. So we also discussed the harms. So consenting the next of kin had several problematic aspects and may not reap any benefits intended in the ethical conduct of research to protect human subjects. So collecting the consent would itself serve as a form of linkage to otherwise unlinked data. It may provoke feelings of grief or stress, and those risks are likely greater than any benefit to the next of kin or the legacy of that deceased patient from the consent. And incidental findings were not going to be returned. Consenting next of kin was really impracticable. The standard of consent for the standard of contact from next of kin would have been a physician in the circle of care. These were patients. You have to imagine this was early in the COVID pandemic. People were just coming in and dying. There was not necessarily a physician contact. There were lab samples, and so not something that was feasible. The other thing is the reason we use next of kin as a proxy, which we all know is not necessarily that great, is that they are intended to make the decisions that the patient would have wanted during a time of loss of capacity. In this case, unlike, for example, organ donation, most next of kin would not have had prior discussions regarding the use of their genomic samples for cohort research. Contacting the next of kin could actually be a breach of confidentiality for the deceased patient. They may not be aware of the details surrounding the death. And given the circumstances of the pandemic, we were also concerned that they might not respond positively to such requests. So most of the work around this has been done by BAC with a systematic review here, as well as empirical studies that can be summarized by a participant quote in their study of a patient who survived sudden cardiac arrest. When you are dead, you're dead, but it would be nice if you can prevent other people from dying the same way. And I won't read through all of these, but essentially in studies that have actually asked next of kin or participants about how they feel about this issue, on the whole, looking at all these studies, most patients are fine with or would like their data to be used. So we ended up writing a paper with a legal expert, Dr. Bartha Knoppers, in Montreal, arguing that the province where she works, the province of Quebec at McGill University, should allow such case-based considerations, as the law there does not, which would allow more streamlined access to secondary research on the tissues of deceased individuals. We contrast that with the laws in Europe, who has much more liberal allowances. We also concluded that the population research during the public health emergency would allow crafting of research and policy that's proportionate to the arising risks, in particularly what in our Canadian system is a universally publicly funded healthcare system. The issue of secondary findings and research on the samples from deceased patients certainly merits consideration, but we did not delve into that here. So the REB passed. This is a Nature paper with about 10 million sequenced genomes. Oh, Jordan's correcting me, but how many? Okay, from all over the world. And they did find genome-wide association pathways to be involved with COVID-19 around viral entry and innate immunity, entry defense in airway mucus, and type 1 interferon that can have practical potential uses. There is another study coming out in Nature about long COVID, which again arose from this data. And all of these, which I won't go into. So that, I think my time is up. So we went through a bit of that quickly, but happy to answer any questions. And again, great to be back. Jordan's waiting for your questions. Good. Oh.
Anybody else? No? Okay. Hi, thank you for a really interesting presentation. So I had a couple of, well, one question was, when you were thinking about the reasons why we ask for consent and research, if you looked at the work of Neil Dickert and others, and I think some of those reasons, what's interesting is they include the reason that people like to have a sense of control, which obviously doesn't apply to deceased patients. So I think that may be, if you continue this work, that may be an interesting thing to think about. But I was curious about one thing that you argued, which was the idea that if a proxy would be less likely to give a positive response, that could be a reason not to ask them in the first place, right? And that, I think, maybe I didn't interpret that exactly correctly, but another way to frame that might be that it's burdensome on the proxy, right? It might cause them harm.
Right.
And I think those reasons are, that type of reason is important to consider, but as you probably know in the history of consent, there's this, history of being more paternalistic because of worries about patient harms, and that has, since been moved away from, with the idea that therapeutic exceptions to informed consent really shouldn't be used in most cases, and that, should at best be a temporary thing. So I wonder if you could talk a little bit more about your thinking there, and maybe it might be helpful to kind of reframe that point slightly.
That's great, thank you. So the first point is excellent, and I certainly will add that to kind of my list. I think I meant it in both of the ways that you interpreted. And so certainly, you know, one of the main arguments is that there are many ways in which we could cause harm to the next of kin. But with respect to that specifically, what I had to do to sort of sort that out in my own mind was go to public health ethics. And it's really something that I think I probably didn't learn enough about or understand. And so it's really a totally different set of principles. And it's one where, you know, potentially the interests of the living override the interests of the deceased or even individuals. And so I think, you know, I can totally feel and understand the discomfort with that particular statement amongst the potential, you know, harms. But, you know, when in the province of Quebec, this research couldn't go forward, this type of research wouldn't be able to go forward, it was really, you know, for that reason, that was sort of part of the conceptualization that, you know, if this is important, that, yes, I guess to some extent, the public health lens is a little more paternalistic because we're saying you have rights to a point. Now, I think if we could have identified very specific harms from not obtaining consent, that point would not have been the overriding one. But it's a very good observation because it's certainly something that I kind of struggled with and had to really look to public health ethics to help answer. So, thank you. Okay.
Oh, Karen? Karen. All right. Hi, how are you? All right, thank you, Dr. Devon. Our next speaker is Dr. Timothy Murphy. Timothy F. Murphy is professor of philosophy in the biomedical sciences at the University of Illinois College of Medicine. He holds a doctorate in philosophy from Boston College and conducts research on ethical aspects of genetic research, fertility medicine, and biomedical research, especially as these affect sex and gender minorities. He's the author or editor of 9 books, and next year, Routledge will publish his latest book, Ethics and Paid Sexual Encounters Among Men. He is also the author of more than 125 peer-reviewed articles that appear in such journals as the Journal of Medicine and Philosophy, Bioethics, Hastings Center Report, and the Journal of Medical Ethics. Professor Murphy is currently a member of the editorial board of Bioethics, and his research has been supported by the U.S. Department of Defense and the UIC Institute for the Humanities. He's been a visiting scholar at the Institute of Ethics at the AMA and is currently a lecturer in ethics at the Rosalind Franklin University School College of Podiatric Medicine, offering instruction in ethics and professional standards for podiatry limited license healthcare professionals. Today he will be covering the drug costs of medical assistance in dying. Welcome.
Thank you and good morning. I hope to live up to my introduction today. Let's see, I'm just going to press a button and that will work. So today what I want to do in this presentation is to talk about covering the drug costs of medical assistance in dying. So in this politically fractured country, medical assistance dying is yet another political football to be tossed around politically and ethically. So what I wanted to do today, I have no disclosures to make, by the way, is to talk about the patchwork of third-party subsidy of drugs for medical assistance in dying where this practice is legal, namely how these drugs are paid for. I'm going to talk about select ethical philosophical objections to subsidy, namely the side that says we shouldn't pay for these things. I'm going to point out the limits of these objections so far as I can understand them. and I will make the case for a justification for third-party payer of drugs for medical assistance in dying. So first, some background considerations. There is differential access to medical assistance in dying by reason of a constitutional decision from the Supreme Court. For most U.S. states and territories, the question of drug costs for MAID is moot because the practice is formally illegal in those jurisdictions. So a national patchwork is the effect of the Supreme Court declaring against the constitutional right to physician aid in dying, and there were a couple of key cases on this from 1997. So as a result, what we have is this particular patchwork, where medical assistance in dying is legal by statute in a number of states, and legal by a court ruling in one state, but across the total number of states in the United States, the practice is illegal. Now, there are proposals percolating in a lot of states, jurisdictions, state legislatures, so this might change, but I don't know. I don't have any crystal ball about this, about what will happen next. But for the moment, this is what the picture looks like for the states and the territories. So, right now, access to MAID in the United States looks like this. Approximately 74 million people live in a state where they are entitled, under certain conditions, when they have a terminal illness, to seek from a physician a prescription which will, they take on their own, which will end their lives. Now, that's the people who live in these states. Technically, in theory, everyone in the United States has access to medical assistance in dying because not all jurisdictions enforce state residency requirements. So, in other words, if one state has it, you cross the border, you go to the next state. Now, so for example, Oregon and Vermont dropped residency requirements in the face of certain lawsuits. But obviously, there's a lot of practical considerations on this. When you're dying, you have to think about crossing state lines to get access to this option. All right. So, there's also a background consideration, differential access with respect to federal funding for these kinds of practices. So not only access to MAID will remain state by state, territory by territory, but no federal funds may be expended on behalf of MAID services. And I quote the federal law here. Federal law prohibits payment for any healthcare item or service or health benefit coverage for the purpose of causing or assisting to cause the death of the individual. Right, so this is the federal law, which would bear on all federal funding sources. It also turns out that there's differential access relative to race and ethnicity. As practiced in the United States, MAID is overwhelmingly the privilege of white people. Just overwhelming numbers. But as people in the United States are economically stratified by race and ethnicity, so too will economic aspects of MAID be stratified that way too. The effects of the cost in this spotty third-party coverage are not studied, hardly studied at all. I've been able to find a couple of anecdotal reports. And the one thing that always strikes me is how generous families are when they're thinking about this. They roughly say, my family was able to do this, my spouse was able to do this, but I worry about the people who aren't able to do this, to find the cost to cover these drugs. So if anybody's looking for a project, here's one right there for you. All right. Now, what drugs are we talking about? Well, the statutes that allow MAID in the various states are silent on the allowable drugs. I mean, they're not spelled out by statute. So you see a variety of the list here of the drugs that have been used over time. I'm not going to go through them all. Some of them are more complex than others. Some have to be specifically compounded. The history of pharmaceuticals in the United States is also the history of drugs used in MAID, which is to say the economic influences come to bear. All right, so what kind of costs are we talking about here? So the reported costs have varied over time and the drug used, not to mention ownership of drug companies. So private equity has made its presence felt in this field no less than in other parts of the healthcare system, and bought up patents to particular drugs and caused astonishing increases in the cost. So early on in 2010, the mean cost was approximately $400. By 2016, that had risen to almost $3,000. And there are even some reports of the drug costing between $3,000 and $5,000. More recently, because of various maneuvers, these costs run approximately $750, $850 charge cost. All right. The Seattle Cancer Alliance put out this particular report a while back. It's on the old side now, but if you look at the third column in from the left, you'll see that the mean costs increased astonishingly over time. So this is the script for the terminal dosage that I'm talking about. Okay, so for these costs, there's a payment patchwork. Federal law, as I mentioned, prohibits payment for any healthcare item, service, or health benefit for the purpose of causing or assisting to cause the death of an individual. So the feds are out of this. This will apply as well to Medicare, Medicaid, TRICARE, Indian Health, VA among the systems affected. Also affecting federal employees, service members, and dependents, veterans, and federal prisoners, among others. All right, so this is a lot of people. Religiously sponsored healthcare providers do not involve themselves in MAID typically. Private insurers vary. There's no state obligation in most jurisdictions to do this, and it's sort of a personal decision for them. One state California does subsidize costs through state money rather than federal money. All right. So this is the patchwork at present, as I said. I don't know what's going to happen in the future. I suspect more states will adopt MAID practices, but we'll see what happens. But I don't expect this patchwork to change. All right. So why don't third parties want to get involved in this? So this is the philosopher side of me. First of all, one rationale for not paying is MAID is not a medical treatment. This is a lethal dosage. It does not serve a therapeutic purpose in the sense of curing an underlying pathology or treating its symptoms. The drugs are used not as medications, but to intentionally bring life to an end. So it's not health care in a limited sense that way. All right, and therefore we're not going to pay for it. Well, my own response to that is that some healthcare interventions clearly serve well-being and or prevention. In fact, some states oblige health insurers doing business in their jurisdictions to pay for in vitro fertilization attempts. Illinois is one such state. And IVF, in a strict sense, does not cure an underlying pathology so much as it bypasses anatomical or physiological obstacles to conception. All right. So the Affordable Care Act also, for its part, mandates coverage of certain preventive services: obesity screening, counseling, breastfeeding, support supplies, vision screening for children, and PrEP. So these are not technically costs that treat an underlying pathology. So I think you can make the case that MAID is therapeutic enough. It's therapeutic in the sense of serving well-being in the same way that IVF constrains the dissonance of infertility, and MAID drugs have a preventive quality to them. Another reason might be that subsidy endorses MAID. So this is the argument that if the government pays for it, it is in effect saying MAID is a good, ethically sound practice. All right. And some people don't like this. They say it sends the message that taking your own life is okay in a moral sense. And therefore, we don't want the government or even insurers to do this, pay for this. All right. I fully and entirely see that practices do have performative effects in respect of their social meaning in signaling whether a choice is morally acceptable or not. But the logically prior question for me is whether MAID is morally acceptable for people with terminal illnesses and the participation of certain healthcare practitioners. So I submit that if we accept MAID as moral, then the effects of subsidy by government are not objectionable in their effects, sending this performative message that MAID is okay. All right. I would also point out that I think it makes sense to have the government and some third-party payers observe viewpoint neutrality. I mean, this is not required, but neither is, but it also isn't optional. I mean, the government doesn't have, it's neutral in respect of people's religious choices. It should be neutral in this choice as well, it seems to me. Or, you know, I'm choosing palliative end-of-life care. All right. Another related argument is that subsidy will increase interest in MAID. Listen, if people are giving out money for this drug, then people are going to want to spend on this drug. All right. So some critics of MAID point to the total number of parties and treat the increase as evidence against the practice. Canada looms large in these discussions for the total number of deaths. A report from 2020 indicates that approximately 45,000 deaths have occurred since 2016 this way. So it seems to me that the kindest interpretation of this objection is that the interest in MAID be an artifact of poor end-of-life treatment. So the worry here is not that the numbers are increasing per se, but are people really flocking to this because they're not getting the end-of-life care that they should be getting? My own response to that is that I think that this is morally, again, morally defensible on its own, standing on its own 2 feet. And what is missing from this objection is an evidence that more use is harmful in its effects than the alternative. So if you want to make this case, you have to really show that something is missing elsewhere. So the worries seem to me that interest in MAID is an artifact of poor end-of-life care are at the moment, in my view, unsubstantiated. It also seems to me from a philosophical point of view that no moral precept requires people respond to the pain of terminal disease and the suffering it entails in the same way. No moral precept requires people to value their end-of-life suffering in the same way. And I think there's a strong and potent defenses on behalf of pursuing medical assistance in dying. All right. One other argument here is that drug costs are morally distinct from other costs in MAID. For all the other costs of taking care of somebody with a terminal illness, this one is somehow different. All right. And therefore we can decline to pay them because they have a material role in the causal death of a patient. Well, let's see what happens here. It turns out that third-party payers do cover MAID costs. They do. So if we look at Washington State, for example, the rules of that state require the physician, number 1, receives a request to test the eligibility of the patient. Physician 2 separately evaluates the patient. Sometimes a third party is required, a psychiatrist, a psychologist. And after all this, the physician 1 writes the prescription. Each physician is paid for these services directly related to MAID. So it's not like the drug cost per se is distinct in a way that other payments are not. Now, I fully admit that the boundaries between general care for disease and pain management in a particular individual and the time spent devoted specifically to MAID can be very blurry. But again, the fact is the physicians are paid for the time spent in their causal role in MAID. Okay, so a range of people and practices already enable MAID. It's unclear from a moral point of view why one contributed cause would be more objectionable than the others, such that it should be excluded from payment, but not the others. So, let me move towards some conclusions here. Public and private payers vary widely in the subsidy of MAID drug costs. Certain objections to coverage involve claims that drugs are not therapeutic, they increase interest in medical assistance in dying, the subsidy morally validates MAID in a performative sense, and the drug costs are distinct in a way that justifies their exclusion. I've suggested these objections do not sustain moral scrutiny. A broad definition of health, on my view, includes well-being, and the circumstances of death matter for those with terminal illnesses. As precedent, third-party payers subsidize costs for purposes of well-being and prevention already. Third-party payers also pay the costs of MAID to parties with causal roles in people's voluntary deaths. Subsidizing MAID drugs stands to equalize access across economic stratifications that mirror racial and ethnic stratifications. Public, and this is my humble conclusion, I don't have a political arm to move the needle on these things, but from a conceptual point of view, it seems to me that public and private payers ought to cover MAID drugs as health insurance, and this is the more ambitious hope that I have, that federal law will be brought into line with this morally defensible practice someday. And these are some references, and thank you. If anybody wants a copy of the slides, let me know. Professor Pope.
Oh, thank you. So can I just ask you to get a little bit more granular on the practical audience of your argument? So on your last slide, you said we should repeal the Assisted Suicide Funding Restriction Act of 1997.
Yeah.
But let me ask you two things. If a state is going to authorize MAID, should that state that, I guess you're going to say yes, but I just want to ask, should that state then cover MAID under its state with state Medicaid dollars? And then the second part is, should the state Department of Insurance mandate that the privates, right, the Blue Cross and Aetna, Cigna, in that state, they should also cover MAID in that state? So I guess that's a strong position, which is not only should you, but if your state moved to the political position that it's going to authorize MAID, should that state A, cover it, and then B, mandate the privates cover it?
I think the states should cover it. And so now the question is whether law should actually mandate the coverage in a way, for example, I believe it is 7 states in the United States mandate health insurers doing business within their borders to cover IVF. So your question is, should they mandate coverage of these costs in the same way? I think the moral argument is strong enough to support that. Again, this is a political, we have 50 states and 4 territories, but I think the moral argument is strong enough to carry across them.
I was just wondering if you could differentiate a little bit in terms of MAID being morally permissible versus a right to die. I think if you take the stance of MAID being a right to die, then the argument for covering it is that we have to defend this right. But if currently, in the United States, we have a lot of healthcare that is okay, but we don't necessarily have a mandate to do that because it's maybe not a right. Just wondering your views on that.
I'm not quite sure I have the question precisely in front of me.
I guess as MAID viewed as a right to die.
Oh, I see.
I see. Morally permissible.
Most of my argument is, in some sense, an argument of consistency. So if you're going to pay physicians for their role in medical assistance in dying, I don't see any logical barrier or logical way to exclude the covering of the costs. I also think on a humanitarian grounds, benevolence grounds, you can make the case that this should be cost as a core function of healthcare. I mean, it's what healthcare is for. So if you want to, I also am going to, I didn't put this in my argument, but it's also an odd thing to me that private insurers won't cover this, because it seems to me that it would be in their own economic interest to do this, so to reduce the total expenditure of costs in this way. So.
Hi, Karen Devon,
Yeah.
Canadian MAID provider here. So just it's not so much a question, but I thought I would just add some context to the Canadian numbers that you showed, and that is often used as sort of anti-MAID argument or even propaganda in my view. But so MAID is 3% of deaths in Canada. All MAID is covered, all aspects is covered through our universally publicly funded system across the board, and it's almost exclusively done by a physician with IV medications. So a lot of these issues are very different, obviously. I should say that when looking at the data, 90% of patients at the end of life in Canada who receive MAID have also received palliative care, and we even know how long they've had palliative care for. And the other interesting aspect is that, you know, the argument that, you know, kind of affluent white people are getting MAID is actually also true in Canada, but the anti-MAID argument is that we are funding the vulnerable and the marginalized to receive MAID. So once you fix this, you're going to get the opposite argument.
Okay. I appreciate that perspective. Thank you. Okay.
All right. Thank you, Dr. Murphy. Our third paper today in the health policy plenary section is being given by William Choi. William is a medical student at the Warren Alpert School of Medicine at Brown University and an active member of the Rhode Island Hospital Ethics Committee. He received his BS with honors in neuroscience and philosophy at the Johns Hopkins University and completed his Master's of Bioethics degree at Harvard. William is passionate about studying diverse philosophical approaches to death and dying and developing patient-centered decision-making models for individuals with neuropsychiatric conditions. He has published his work in journals such as the Journal of Medical Ethics, Theoretical Medicine and Bioethics, and Neurology, and is the recipient of multiple awards, including the 2022 Beecher Prize in Medical Ethics, the 2022 ASBH Student Paper Award, and the 2023 NIH IRTA Summer Fellowship. He aspires to pursue a career in neuropsychiatry and neurorehabilitation and hopes to guide his clinical practice with his academic work in neuroethics and philosophy. Welcome.
All right. Hello, everybody. I am very excited to be presenting on a new metalinguistic framework for determining circulatory death in NRP using a lesson from brain death. I have no relevant disclosures. So first, I'll be providing some background information about normothermic regional perfusion, or NRP, and the controversies associated with it. I'll then attempt to resolve some of these controversies by drawing a parallel to the brain death debate over the inherent uncertainties of diagnosing death, and ultimately proposing a new metalinguistic framework to approach the problem. And if time permits, I'll also go over some potential objections to this proposal. So NRP is a fairly new technique used in organ transplantation. In brief summary, a patient who experiences cardiac arrest is declared dead after the cessation of their circulatory functions, usually for about 5 minutes. Afterwards, the donor's blood vessels to the brain are occluded to prevent reperfusion of the brain, as blood is then recirculated throughout the body using an external machine that can warm and oxygenate the blood. And the purpose of this procedure is to minimize ischemic damage to the organs after circulatory death. Depending on where the organs are being perfused, organs can be limited to those in the abdomen, such as the liver, the pancreas, or kidneys, and also include those in the thorax, such as the heart and the lungs. So this kind of procedure was documented as early as 1997, when an ECMO machine was used to circulate blood in a patient's body after death to facilitate organ procurement. Since then, it's been practiced throughout medical centers in the UK and Spain, and some medical centers in the United States as well. As mentioned before, NRP must be performed after the patient is declared dead according to the circulatory criteria, which is defined by the UDDA, or the Universal Declaration of Death Act, as the irreversible cessation of circulatory and respiratory functions. And this is in order to meet the dead donor rule, which is an ethical norm that organ donors must be dead before organ procurement. So given all this information about NRP, what exactly is the nature of the controversy over this procedure? Let's go over some of the benefits that proponents of NRP might argue, which include the improvement in the quality of organs that are procured, as well as the increase in the number of viable organs, as well as potentially improved outcomes and graft survival in recipients of organs from NRP donors. However, critics of NRP share a major concern, and that is the question of whether the donor is truly dead if blood is being recirculated into their body after being declared dead according to the circulatory criteria. And I encourage everyone in the audience as well to, if you are an organ donor, or to put yourselves in the perspective of an organ donor, if you would consider this to be a potential act of resuscitation or not. So in 2021, the American College of Physicians published a statement of concern that raised two major issues with NRP. The first one being that the fact that recirculation of blood in the donor's body reverses the circulatory criteria by which the donor was declared dead, thereby resuscitating them. The second issue is that the process of occluding the cerebral vessels to the brain is an act that causes brain death and therefore constitutes an act of harm. 3 years later, this year, the American Transplant Society published a consensus statement that offered some counters to these issues, arguing firstly that the reperfusion only applies to localized organs in the body and does not constitute, for example, spontaneous whole body circulatory function that they perceive to be constitutive of life. Secondly, they claim that since the donor is already dead, that when cerebral vessels are then occluded, they are not causing death in a patient who is already declared dead, but rather preventing any chances of unwittingly restoring consciousness or perfusion to the brain. The focus of the rest of this presentation will primarily address the first arguments that are outlined in both the ACP and the ATS statements regarding whether the patient is truly dead or whether they are resuscitated. Now, one might turn to the law, such as the UDDA, to seek clarity in determining whether one is dead or not. And on face value, it seems like the UDDA defines death simply enough, asserting that death is equal to essentially having irreversible cessation of circulatory respiratory functions. However, upon further scrutiny, it leaves many questions unanswered. For example, what does it mean for the cessation of circulatory respiratory functions to be irreversible? And to what extent is circulation important for life? Is it the whole body? Is it limited to mere parts of the body? Legal consistency may be key in this debate, but the very legal standard by which we are supposed to be consistent with is not entirely clear, and furthermore, it requires a more careful analysis of the metaphysical assumptions that inform how we are supposed to interpret the legal standard. And this brings me to the topic of the uncertainty of death. So the debate over NRP, whether it is resuscitative or not, I believe rests on some strong and competing metaphysical intuitions about whether the patient is dead or alive. And in this regard, there are some important parallels that could be drawn to the brain death debate. A fundamental conflict in the brain death debate is whether the diagnosis is one of true death or, and if so, what justifies irreversible apneic unconsciousness as a standard for death, in the words of Bach-Trug. Many philosophical arguments have been made for either side, appealing to various different theories of death. And while each of us might have a personal preference for what we believe to be death, it is clear from the brain death debate that there is no single metaphysical standard that can be settled on, and I believe this is for a good reason. Death is metaphysically elusive. This is much evident from the current controversies over brain death and the indefinite pause on the revision of the UDDA, in part due to these conflicting metaphysical intuitions. Now, we can use some empirical proxies to estimate when someone has died, such as the oxygenation levels of their blood, but we cannot rely on empirical evidence to determine whether one is metaphysically dead, because metaphysics definitionally transcends our empirical sensibilities. Therefore, one solution to this controversy of brain death would be to recognize the very concept of brain death as a normative one that is shaped not only by different metaphysical intuitions, but also societal interests in preserving our hospital resources or procuring more organs. And perhaps it is also our duty to question some of these normative interests as well. Similarly, the debate about whether someone who undergoes NRP is truly dead seems, at least in part, to boil down to differing metaphysical intuitions rather than empirical evidence that one is dead or alive. Proponents of either side may firmly believe that the other has some mistaken belief or an error in logic or consistency, but it cannot be denied that both sides are driven by very real and deep-seated intuitions about what life and death look like. So how might we resolve these metaphysical convictions about what truly constitutes death? The answer that I posit is that we cannot, at least in terms of empirical evidence. The consequence, however, need not be an ideologic stalemate between these different conceptions of death. Instead, I believe we can adopt a new approach that considers how we use and deploy the concept of death based on its pragmatic considerations and effects without having to make further metaphysical commitments. I propose a new metalinguistic framework that shifts the paradigm of the NRP debate away from trying to precisify biologic conditions that are required for the metaphysical status of death and towards a more pragmatically fruitful consideration about how declaring the words dead or declaring the word life for an NRP donor normatively impacts patients and families and clinicians in society at large. And the impetus for developing this framework for the NRP debate is the current state of the brain death debate, which is ideologically gridlocked due to conflicting intuitions from different experts and lay people about whether brain death is truly death. And I believe if we fail to recognize that the debate over NRP similarly boils down to conflicting metaphysical convictions, we risk falling into the same ideologic gridlock. So under this new framework, we get to focus on what are the socio-functional roles that are achieved by those who want to call NRP donors dead or alive. So for those who might believe NRP donors are dead, they might assert the following as important pragmatic benefits, such as the increased number and quality of organs, or optimizing the fulfillment of donors' desires to donate as many organs as they can. While those who believe NRP donors are in fact resuscitated might argue that for example, they can prevent the possibility of donors gaining consciousness or provide an ease of mind to those who hold some of these metaphysical beliefs. If we are to believe that people are entitled to pursue or not pursue NRP according to their perception of its pragmatic consequences, while leaving open the metaphysical question of whether or not it is truly performed under death, I would like to at least entertain the possibility here of a choice-based pursuit of NRP. And this requires two very simple steps. The first one will be to inform the patient and the family to clearly communicate what the procedure entails and to obtain their beliefs about whether such procedure constitutes resuscitation. The second step will then be to obtain consent. And so if a patient or a family holds the belief that NRP is restorative of life, then they can opt not to do NRP. And on the other hand, if they believe NRP is not resuscitative, then it is ethically permissible, at least according to their beliefs, that NRP be performed. A caveat here is that we may need further research to demonstrate that NRP would not restore consciousness, as an aside. In the interest of time, I'd like to just go over one main objection here, which is that some critics who believe that whether NRP is resuscitative or not either has a definitive answer or at least ought to have a definitive answer, at least for the sake of legal consistency. I'd like to respond here by pointing out it's important to establish that insofar as NRP proponents hold genuine, deep-seated beliefs that NRP does not constitute resuscitation, it's simply not enough or productive to appeal to standards of legal consistency or objective truth when those very concepts are subject to interpretation according to differing metaphysical intuitions. Therefore, the purpose of my metalinguistic framework is to move beyond these arguments that are based on deep-seated metaphysical arguments, which, in my opinion, can be futile to debate sometimes. And instead, it allows us to focus the debate on a more fruitful topic of the pragmatic benefits about what the socio-functional roles of death or the socio-functional role of life allows us to fulfill when we apply them to NRP donors. And in doing so, we do not have to arbitrarily impose one metaphysical standard over another, especially on those who do not believe it, and we could potentially allow the procedure to be pursued by those who do want to remain consistent with their own beliefs. So ultimately, in conclusion, I'd like to propose to reframe the NRP debate according to this metalinguistic framework, potentially as well a choice-based system for pursuing NRP in order to democratize decision-making and conceptual freedom to those who have diverging metaphysical beliefs about death. And as just two important future calls for research on firstly, the research on the possibility of regaining consciousness under NRP, as well as more survey studies on public opinions and attitudes about what people think, whether or not NRP is ethically permissible. These are some of my references, and I'd be happy to take any questions. Thank you.
Thank you for a very thought-provoking talk. So I had two questions. One is you make the argument that death is a metaphysically elusive concept. And I was wondering if you were arguing that we'd never know when somebody is dead, or that the boundary of death is metaphysically elusive. So, presumably, I don't know if you're arguing that William Shakespeare is not necessarily dead, that there's some metaphysical way in which he's still alive, or if you're arguing that when we're talking about brain death and that very specific line, that finding a precise line is elusive.
Yeah.
And the second question I wanted to ask is what your proposal adds above other proposals that are out there. So David Magnus argues that death is a social concept. Others have argued that death is a legal fiction. So what do we gain from this approach? But thank you for a really interesting.
Yeah, no, thank you for the questions as well. So to answer your first point, it is, I believe, the latter that you described, which is, I think there are very clear states, and especially, before the age of rapid medico-technological development, it was very clear to determine when someone is dead or alive. And I believe, back when, medical technology was very limited, we would look to the standards of putrefaction to determine when someone has died. I think largely these questions about brain death and NRP are due to the fact that medical technology has really expanded the gray zone between what is death and what is life. And so I think within the gray zone, it is difficult to precisify the line that we might consider to be life or death. And so that's what is the relevant question here. And as to your second question about what this new framework adds, I like to argue that it allows us to sort of detract from the metaphysical convictions, and not necessarily to deny that they exist, but rather I think it provides an opportunity for people to actually be able to have their metaphysical convictions validated, and at the same time to recognize what are some of the pragmatic consequences of pursuing NRP or not pursuing NRP. And so I don't think it's a matter of just calling death a social construct, but rather, what are actually the pragmatic benefits we can focus on, while also leaving the metaphysical question open to interpretation or open to your personal belief, and have that be validated as well. Great.
Fantastic talk, and I think you've sort of nailed a lot of key elements here. A couple of things I wanted to point you to: the survey literature about the dead donor rule itself and general public attitudes, where most people would say, if I've made the decision to withdraw life support, or my family's made it on my behalf and I'm going to be dead, it's okay to take my organs out before I'm dead. Like 2/3 of respondents say that, right? And the dead donor rule serves a very important purpose that we only pursue towards DCD after we've exhausted all efforts to return the patient to a normal, healthy life, right? And then we're sure that they would want to withdraw life support. But I think you've sort of nailed that. What we're talking about is timing and sequence, and most donor autonomy needs to be highlighted and centered a bit more. But so great talk. I hope the comment was useful.
No, great. Thank you very much.
you for your wonderful discussion. Sorry, I'm short. I think you've added a really fresh perspective to a complex argument. I have two questions. I don't know if any of us will have the answers to them, but I guess, is it ethical for us to be doing this procedure to patients and not consenting or failing to disclose? And then what also then are the ethical implications of trying to obtain consent and then having an adverse impact on the organ donor pool, perhaps, because we're scaring or, creating something contentious about organ transplant in the media? Because those are reasonable and concerning from the consent process.
Yeah, thank you for the great questions. Just really briefly to address the first point, I personally do think it is important not to further obfuscate what the procedure constitutes for patients and families who may potentially opt into NRP, and I think it is actually to the benefit of further informing them, and I think, as the previous attendee said, most people, I think, have diverging views about whether or not they would donate their organs, even if they are technically considered alive. And I think, sort of bleeding into that second question, I think that I think there is some further research that can be done in terms of, how willing people are willing to donate their organs, despite the fact that, some of these arguments are being made. But I think there have been at least some literature pointing to the fact that, at least in the case of brain death, which I am more familiar with, that people are willing to donate their organs, even if brain death itself is not considered an actual death, but rather, like a state of permanent unconsciousness or something like that. So, thank you for the questions.
Fantastic stuff, Will. Awesome presentation. I learned a lot. Actually, I wanted to come here first to ask a question, but also get a better picture of you. So if you could go back a few slides to something that looks really good. Yeah, absolutely. And while you're doing that, so my question sort of is awesome stuff. Perfect.
This one?
Yes, and I actually do have a question. So so I'm just sort of wondering how this would play out, maybe in actual practice when we're attendings and so on. So I guess the gist, the core of your argument is to say we can move beyond like metaphysical loggerheads at metaphysical intuitions about death, and then we can go on to what you propose, the meta-linguistic democratic method or process of resolving that. But then sort of what happens when even that goes at a conflict? Do you just lead to another dead end, or do you just lead to some regress? Like, for instance, there's a patient who has died and NRP is proposed, and then you have family members who sort of are in conflict about their own like metaphysical, like ontological like assumptions or intuitions about, is this person really dead with NRP, or no, is this person really alive with it? How would you sort of move move past that debate and, I guess in a physician role or abstracted beyond that, sort of like mediate and adjudicate between those conflicting like assumptions?
Yeah, that's a really great question, and I think there are a lot of complex layers to it. Like, should we have a default option for those without family or friends who are unable to express their preferences? But at the very least, I don't view this as any different from other normal surrogate decision making we have to do for those who cannot speak for themselves. And so I would imagine we would sort of follow through an existing process of surrogacy, and if there are like metaphysical conflicts, that we sort of honor the surrogate who we deem to be closest to understanding what the patient would have wanted. But we could chat later too.
Yeah, absolutely.
Appreciate everyone's questions. Thank you.
No, thank you so much.
Just to say that was a remarkable presentation, and as a medical student, you should be extraordinarily proud of the work that you've done. I think most of us in medical school were sort of sitting in the back of the classroom, chewing on our hair. All right. The last talk of this amazing plenary session will be given by Ava Jordan. Ava serves as the Research Program Manager for the Pediatric Research Ethics and Policy Prep Program at the Lurie Children's Hospital. Under the leadership of Professor Seema Shah, JD, the PrEP program seeks to unlock the unfulfilled potential of biomedical and public health interventions by advancing ethics and policy research apace with scientific discovery. Ava is a UChicago alumna, completing the Master of Arts program in the Social Sciences with a concentration in psychology in 2019. And today she will talk about identifying priorities for pandemic preparedness in research ethics and policy, a community and expert engaged approach. Welcome.
Hello, everyone. Good morning. Thank you for that introduction. Like she said, my name is Ava Jordan, and I'm the Research Program Manager of the PrEP program at Lurie Children's Hospital, which is directed by Professor Seema Shah. And I'm very excited to be here with you all today to share some of our work. I have nothing to disclose. So my talk is structured into 5 main sections. I'll begin with a brief background and then walk you through the 3 phases of our current study and some potential next steps. To begin, I wanted to share this quote from the WHO Director General when announcing the end of the COVID-19 global health emergency in May of last year. He said, "We must promise ourselves and our children and our grandchildren that we will never make those mistakes again." This quote really encapsulates our project because it acknowledges that mistakes were made in pandemic response, but it also includes a call to action to be better prepared for future generations. Throughout the US pandemic response, the needs of children were often neglected and only really considered as an afterthought. Pandemic communications about children and COVID, especially early on in the pandemic, lacked necessary evidence. Children were deprioritized in vaccine and treatment research where they suffered from low recruitment numbers. Retrospective analyses that did include children tended to focus on school closures and virtual learning rather than the indirect effects of lockdown and the effects of isolation and the severe impact on children's mental and physical health and the increased but less visible rates of domestic violence. Global inequities may have exacerbated these adverse experiences for children around the world. So, in order to begin to remedy some of these issues, our team came up with the current project, Startup PrEP, or Setting Priorities via Rapid Engagement of Community Partners for Pediatric Research Ethics Preparedness. The objective is to create an action plan that combines expert opinion with community perspectives to ultimately select feasible, high-impact initiatives that can accelerate pediatric research ethics and policy in advance of future pandemics or other public health crises. To accomplish that objective, our study has taken a 3-phased approach. In phase 1, we identified 20 pediatric research failures using an expert advisory board and community engagement. In phase 2, we created an infographic and conducted focus groups with adolescents and parents. And in phase 3, we will finalize a top 10 list of pediatric research shortcomings seen throughout the pandemic via surveys of adolescents and parents. Over the next several slides, I'll take a closer look at each of these phases, beginning first with phase 1. The first step of phase 1 was to assemble our expert advisory board, or the EAB. This group included professionals from the fields of infectious disease, public health, public policy, and bioethics, and their names and affiliations are listed for you here, and you can see that this group was assembled from various institutions across the US. The goal of this initial meeting was to produce a list of pediatric research shortcomings seen throughout the pandemic, and our group came up with a list of 20 lessons learned that we'd be happy to share with anyone interested after the talk. We next took this top 20 list to adolescents with Lurie Kids Advisory Board and students at Walter Payton High School to make sure that we were presenting this information in a way that was easily digestible by teenagers. So at the end of phase 1, we had this initial top 20 list created by experts and honed by adolescents that would take us into phase 2. During phase 2, we developed an infographic flyer designed to quickly educate parents and adolescents. We then conducted 4 virtual focus groups, 2 with adolescents and 2 with parents. Each focus group provided feedback on our infographic and that initial top 20 list developed in phase 1. We then analyzed the focus groups using thematic analysis. Here is just a quick peek at our infographic that I'm sure none of you can read. But again, we'd be happy to share this with anybody interested after the talk. Now I'd like to discuss some themes that we uncovered through our work with focus groups and with parents and adolescents. Beginning first with connections between communication and trust. So it's clear that the issues of trust and communication were very important to our focus group members, especially the parents involved. One parent we talked to talked about how they didn't trust the sources that we cited when developing our infographic. She did not trust the CDC, the WHO, and the New York Times, saying that the CDC is BS too, and that this flyer seems sus. Another parent shared that she does not trust any data or statistics because she lies whenever she's asked to fill out a survey. She was a Black woman and she indicates on surveys that she's a white man and inflates her income because she doesn't understand or doesn't trust how this information will be used. Other parents really talked about, specifically during the pandemic, how lots of information was seen as politically or practically motivated rather than scientifically driven. The next theme that we talked about with our adolescents and parents was that one size does not fit all, or really one size policies do not fit all. Lots of our parents shared the difficulties of masking for children, especially children with complex medical conditions and or disabilities. We also spent lots of time discussing the differential impacts of school closures. One parent shared that she and her children were unhoused during a period of the pandemic, and even though CPS, Chicago Public Schools, provided devices for remote learning, they didn't have anywhere to charge these devices to connect to Wi-Fi, and so her kiddos really missed out on large periods of virtual learning. Which leads me to the last theme that we uncovered from our focus groups, but talking about dropping the ball on children's psychosocial needs. So both parents and adolescents were very concerned with the mental health effects of school closures and the social challenges that children are facing in the wake of COVID-19. This brings us to the third phase of our study, which is the phase that we're currently in. And right now we're partnering with the National Opinion Research Center right here at the University of Chicago. And they're currently fielding a survey of parents and adolescents. Participants in this survey were first given our infographic, and then they were asked to rank each of our top 20 lists from experts as a big problem, somewhat of a problem, or not a problem. And at the end of the survey, results will be analyzed to develop that top 10 list for addressing limitations of pediatric research ethics and policies seen throughout the pandemic. So, like I said, this survey is ongoing, but I do have some preliminary results to share with you all today. As you can see, we've actually surpassed the number of parents that we were hoping to enroll. We have responses from 1,674 parents, but we are still actively recruiting adolescents, and we currently have responses from 375 adolescents. Again, here's just some preliminary findings, so these are subject to change, but both parents and adolescents ranked the risks of school closures and the mental health crisis, as two of the highest priorities from the pandemic. Moving on now to the top 3 not a problem rankings, or the lowest priorities for parents and adolescents. Both parents and adolescents ranked children not having early enough access to vaccines, and the delayed inclusion of pregnant and breastfeeding people in vaccine research as 2 of the lowest priorities from the pandemic. While there were several priorities that adolescents and parents agreed upon, there were also some interesting disagreements that we want to highlight for you all now. Starting first with communication about masking. So parents ranked this as the second highest priority, and adolescents ranked this as the second lowest priority. Again, that was out of that top 20 list that we presented them during the surveys. Also, on a more anecdotal note, the issue of inequity came up both obviously during our survey, but also throughout our community engagement with adolescents and during our focus groups. So parents ranked the fact that the products of research, such as vaccines and treatments, were not shared fairly with different groups in the US as being the second lowest priority from the pandemic. and adolescents ranked this as the 5th highest. But again, on a more anecdotal note, adolescents through our community engagement work and during our focus groups were very concerned with the issue of global inequity and global injustice. And that was just one interesting disagreement or difference that we wanted to highlight for you here. Lastly, I'd like to discuss some limitations of our study. The first being that we may be experiencing some recency bias. At this point in time, the mental health effects of the pandemic might be more salient to adolescents and parents because we're in the midst of a mental health crisis, and they may be less concerned with the more immediate issues surrounding COVID-19, such as vaccines and treatments. Another challenge was that parents and adolescents might not be seen to have insights into the key challenges of pandemic response. We tried to tackle this particular limitation by starting first with those expert identification of issues and then asking adolescents and teens to prioritize them. Also, we initially designed the infographic as a way to try to educate adolescents and parents as a way to quickly educate them, but this may have had limited efficacy because of the polarized nature of the world that we live in now. Finally, the last limitation is just the need to generalize these findings to another type of pandemic that may occur in the future or to some other climate disaster. Again, like these situations that could arise may have similar effects on kids and families, and kids and families might have similar experiences. So it's still important to address these issues, and some of the data or some of our findings might be helpful in telling us how to do exactly that. Which leads me to the last section of my talk, discussing some next steps. We'd love your feedback on our current project and welcome any ideas for future research collaborations. But as far as next steps that Seema and I have discussed, we really want to issue that call to action to do the work that's identified as most important by experts, adolescents, and parents. We want to convene our expert advisors and collaborators along with parents and adolescents to identify the top priorities and low-hanging fruits that might be modified relatively easily. Finally, in order to address pediatric pandemic preparedness on a more global level, we would love to do a comparative analysis of failures and priorities in different countries and contexts. Finally, I just want to take a moment to thank everyone who played a role in this study and without whom we would not be able to complete this work. Our study team members, our funders at the Pediatric Pandemic Network and HRSA, some key collaborators, including Jackie Burke, who volunteered her time to help us with our focus groups. She served as a moderator for 3 of the 4, and finally, our recruitment partners. Thank you so much.
Outstanding, really important work. If you had to pick one thing for public health policymakers for the next pandemic to take away, like what should they do differently based on your findings?
Wow, quite a big question to start off. You know, I feel like throughout all of this work, I don't know if there is one thing. There's sort of a myriad of issues that we could tackle. I think the most important thing now is really preparing for what could come. And I know that's like a very hard issue. It's very hard to predict what we may see in the future. But I think that pre-planning, I should say, and having policies in place for what to do in certain situations, or when schools should close, what levels things should happen at, when businesses should close or businesses should reopen, like having a more clear set of policies around those issues may help us be better prepared and hopefully alleviate some of the confusion that we experience throughout COVID-19.
Hi. So could you say a little bit more about what your expert panel was actually asked to come up with, like what the prompt was? And the reason I ask is because, like COVID response is pretty controversial. It was controversial among experts. It's also controversial among the public. I'm not sure how much consensus there's been since among experts, but my guess is that you probably wouldn't find like a consensus statement of 20 claims about like what did we do wrong during COVID among experts. So like the examples you gave seemed more like deficiencies than mistakes, which is how I thought you framed it, right? So for example, it's too bad that we don't have enough research in advance about what school closings are going to do to students. But like, did all the experts agree that like school closings therefore were a bad idea? Because I feel like that might still be controversial. So I wonder, like, could you say a little bit more about the prompt and kind of what you're trying to get out of this expert consensus?
Sure, of course. So that initial meeting of the expert advisory board, it really was more of a discussion. So it's not like we gave them a clear prompt and we were like, you have to hit 20 mistakes made from the pandemic and, it's going to be very black and white and this is how it's going to go. It really was a discussion amongst lots of different people. And I think that the things that were important to some were not important to others. And there was a fair amount of like disagreement. So it wasn't it wasn't black and white, I guess, is the main takeaway that I can tell from that. And as far as like we've also worked with them throughout. So we've shared iterations of this, like whenever we got feedback from like our initial focus groups and things like that, we always went back to the expert advisory board with those results to see what they thought and if they had changes to make or suggestions or areas that we could improve our study throughout. I hope that answers your question in some way. Thank you.
Hi, thanks for this really interesting presentation. I'm Elizabeth Lanfear from Cincinnati Children's. And so I guess an observation and then a question.
Sure.
So the observation is just it's interesting to see how your data helps maybe see areas of convergence. So if experts and kids and parents are all seeing school closure as something really important to avoid, then certainly there's all sorts of opportunities for like more prevention work so that doesn't have to happen. That I think could really help, could inform future, I want to say political initiatives, but that may not happen now. So my local level, everyone. Right. But I think that my question is a little bit around the really surprising to me data around both parents and kids deprioritizing pediatric access to vaccination, like not the bubble I live in at all and not the work I was doing as a parent and ethicist. But I'm wondering then how you think about your data in the kind of context of like this feedback loop in which they were also told that vaccines weren't important and what we should think about that ethically and pragmatically.
I mean, that's a great question. I think it's going to be a challenge that we'll all have to face moving forward. I don't know if I have a set answer to this, but I do think that I think there are a few things that I would want to point out. So I think moving forward, if this is such a difficult way, I'm not, I'd love to talk to you more about this after. I don't know if I even have a set answer for you now, but again, I'd love to connect after this and talk more.
Thanks so much.
Thank you so much.
Because everything is just so politically charged now, and you already had parents saying that they were not telling truth on surveys, how do you really move forward? How do you gain public trust? How do you know that somebody is actually telling the truth? Like, where do we your work is really important, but I'm just concerned about where do we go from here? My worry is that we're just going to be stuck in this space where we're not getting any real truth from people. Like they don't trust us. We're not sure we really trust them. Just wondering, like, how do we move forward from here?
That's another great question. I mean, that is such a worry. Specifically, like, especially in our focus groups, I feel like that was the first theme we identified, and it was also just like a topic of conversation the entire time, even if we were, trying to steer conversations elsewhere. So it is an issue that we're going to have to tackle in some way. And again, I don't have the answers. I do think that having clear messaging and also acknowledging when we don't know the answer. I think that was a lot of what parents brought up, especially during focus groups when we had these more anecdotal times with them, was that they felt like the messaging throughout COVID oftentimes was, obviously it was an evolving disease that we were learning more and more about, but parents felt like the things that were true at one point in the pandemic were no longer true later. So I do think that there needs to be a better way of communicating when we are uncertain of certain things, and just acknowledging that there is going to be change. And I don't know if that was necessarily done in the best way throughout the pandemic, but again, that's like a huge challenge that I don't think that there's one feasible response to, and it will be something that we'll have to work through in the future.
So really excellent presentation, Ava, and I thought the questions were great. One thing I will say about the issue of the experts is there was this agreement on, I think deficiencies may be a better word than failures, but it was really focused on what research or evidence needed to be gained to do this better and what were the things that were overlooked. And there was consensus on that. Whereas, the question about when specifically to close schools as a policy matter, I think is a different kind of question where you might find more disagreement. I think this final set of questions really illustrates like the meta lesson from this project, which is that communication right now is exceptionally difficult in a fractured environment that we live in on multiple levels, including media and social media. And we did see some people who trusted the CDC, the WHO, and Tony Fauci, and others who did not. So I think part of what you're suggesting, Ava, is this idea that we have to think about multiple fronts on which to communicate with people, but there was one common thread, which was even the people who did not trust these sources of information still would trust members of their communities. So, the lesson I'm taking right now as a larger lesson is this need to build communities to educate in a way that can have these ripple effects across communities at the local level, which right now is more important than ever. Thanks.
Okay, so we're about to take a break, but before we take the break, I want you to make some informed decisions, okay? So our break will go until 11:20. At 11:20, we're going to have small group breakout sessions, and so I would encourage you to look at the agenda and decide where you would like to go, what papers you would like to hear discussed, and I'll ask that people sort of distribute themselves among the tables based on your interests. Those will be 15-minute talks and 10 minutes for discussion each, and again, it's a smaller group. After the breakout sessions, lunch will be from 12:10 until 1:30, so the whole idea is for active engagement, continue the discussion over lunch. And then at 1:30, we're going to begin concurrent sessions. So you can come back here and there will be papers presented on general clinical ethics, or you can go downstairs to the Little Theater where there'll be an excellent panel on what makes a clinical decision support tool fair. And so we are now at a break, so enjoy, and we'll see you all soon.